All attendees are in listen-only mode.
Good evening, everyone. It is May 27, 2014. It is 9:06 p.m. We're going to go ahead and go over homework assignment number 24. We have one more assignment left, and then we'll be completing 250 topics that are commonly asked on the exam. Tonight we're going to go through number 24, and we have almost completed 250 questions, and Jeff here tonight, I see he's here. I did have another candidate that was supposed to present tonight. Unfortunately, she was unable to make it, and I didn't get her homework assignment in a timely fashion. So I do want to thank Jeff for doing such a great job always of doing his homework assignments, and I did receive it, and I'm going to go ahead and have him present tonight. So Jeff, I hope you're ready. If not, I can always have somebody else read it. It's not a problem. So Jeff, I'm going to go ahead and pull you up here.
Hello.
Hi, Jeff.
Hello.
How are you?
I'm fine.
Isn't it great that you get to do this again?
Yes, I love it.
You're so funny. Okay. Are you coming to Chicago or coming to Newark? I can't remember.
Chicago.
Wonderful. I'm looking forward to us meeting again. We're going to have a great time.
Right.
Okay, number one.
If a patient is diagnosed with breast cancer or ovarian, what in her history will qualify her for BRCA testing? For example, 50-year-old with ovarian cancer and mother who was diagnosed with ovarian cancer, would she benefit from BRCA testing? And now what I pulled up here was the U.S. Preventive Services Task Force recommendations on testing for BRCA. Now, thing is, the question was asking something about what in her history would qualify her if she was 50 and it looks like someone in the family had breast cancer. Now, what I put here is the population asymptomatic women who have not been diagnosed with BRCA-related cancer. So does that mean I did this? I didn't quite answer it. We have
I don't know. I think the risk assessment thing. I don't know. Let's go through this chart because I thought this chart was actually pretty good.
Yeah, I liked it.
Yeah.
So it says screen women whose family history may be associated with an increased risk for potentially harmful BRCA mutations. Women with positive screening results should receive genetic counseling and, if indicated, after counseling, BRCA testing, and then do not routinely recommend genetic counseling or BRCA testing to women whose family history is not associated with an increased risk for potentially harmful BRCA mutations. So risk assessment, family history factors associated with increased likelihood of potentially harmful BRCA mutations include breast cancer diagnosis before age 50, bilateral breast cancer, family history of breast and ovarian cancer, presence of breast cancer in greater than or equal to one male family member, multiple cases of breast cancer in the family greater than or equal to one or more family members with two primary types of BRCA-related cancer and Ashkenazi Jewish ancestry. Then several familial risk stratification tools are available to determine the need for in-depth genetic counseling. Then screening tests, genetic risk assessment, and BRCA mutation testing are generally multi-step processes involving identification of women who may be at increased risk for potentially harmful mutations, followed by genetic counseling by suitably trained healthcare providers and genetic testing of selected high-risk women when indicated. Tests for BRCA mutations are highly sensitive and specific for known mutations, but interpretation of results is complex and generally requires post-test counseling. Treatment interventions in women who have BRCA mutation carriers include earlier, more frequent, or intensive cancer screening, risk reduction medications, tamoxifen or raloxifene, and risk-reducing surgery, mastectomy or salpingo-oophorectomy, balance and of benefits and harms. In women whose family history is associated with an increased risk for potentially harmful BRCA mutations, the net benefit of genetic testing and early intervention is moderate. In women whose family is not associated with an increased risk for potentially harmful BRCA mutations, the net benefit ranges from minimal to harmful. USPSTF has made recommendations on medications. Which of the following is least likely to benefit from BRCA testing? 42-year-old with breast cancer and sister with ovarian cancer. That person, I think, would benefit. 50-year-old, although they already, 50-year-old with bilateral breast cancer, 50-year-old with ovarian cancer, who was also diagnosed with ovarian, who was also diagnosed with ovarian. Did you mean 50-year-old with breast? 53-year-old.
With ovarian cancer.
Ovarian cancer twice.
Oh, it was also, yeah, that's what I meant. Sorry. But hey, at least you know what I meant.
Right. 53-year-old.
Let me just check my notes really quick and make sure that was the same thing that was in the notes. I'm pretty sure it was. It's kind of like, my notes are kind of like all over. Towards the end here, I was digging to find as many things that I didn't list during the course of the year that I wanted to list, but I thought they were too confusing. And this was one of the ones that I had a limited amount of information about. Let me see here. I'm pretty sure that's not it. Here, hang on just 1 second.
Okay.
That chart, where did you find that chart at? That's actually...
So I took that, I think I was actually was looking at, I may have been in, I can't even remember, I think I was in Up-to-Date, and then I clicked on the link for the U.S. Preventive Services Task Force.
Oh, here, I found it. Yeah, I think that's actually pretty good. Wait a minute, let me just get this up so I'm just organized. All right. In my notes, this is what I have here. And I'll read exactly what's in my notes. I don't like to put up on the screen what's in my notes because my scribbling is just a mess here. It says, least likely to benefit from BRCA testing. And this is exactly what's in my notes. A 42-year-old with breast cancer, sister with ovarian, comma, 50-year-old question mark, year-old with bilateral breast cancer. Okay, I got that.
Uh-huh.
50-year-old with ovarian cancer whose mother was also diagnosed with ovarian cancer.
Oh.
Whose mother. There it is. Okay. With ovarian. Okay. Sounds like, okay.
And 53-year-old with a cousin with breast cancer. Which song is least? This is a hard. I'm not least likely to benefit. So how about? Well, we've got two of them that have breast cancer. Least likely. What about the 53-year-old with a cousin with breast cancer?
Right, she doesn't have breast cancer.
Yeah.
She just says her cousin has it.
Right.
So I think
Right.
she's like, oh well, I mean,
Yeah.
I don't think she's going to benefit from it. I think all the other girls will benefit from it. So
Right.
And somebody else texted me on this also. Yeah. So
Got it.
yeah, this is a good. I like that chart. That chart was very good. So I'm going to get it up here. I mean, this whole thing is just very important. All right. Okay, now I see you. Did you cut and paste this from Up to Date?
Yes.
Because it's a chart that you did like a snip test on or a picture.
Yes.
Okay, that's fine. Because I tried to make it a little bit bigger in a different font, but it wouldn't let me because you had cut and pasted. But that's all right. Don't worry about it.
Okay.
That's right. Okay, number 2.
Which birth control methods decrease milk production? Discuss most to least in all forms of birth control. Yeah, so I basically did just cut this out, and I've got barrier methods. I don't know that I went most to least, but barrier methods, non-hormonal methods of contraception, barrier, copper, IUD are preferred to nursing mothers because they do not have systemic effects. Theoretic concerns that hormonal contraception may interfere with lactation and that transfer of hormones into milk may pose a risk to the infant. So you have the intrauterine, breastfeeding women can safely use the Paragard or the Mirena. WHO suggests delaying insertion of a leave-on or gesture-releasing IUD to 4 to 6 weeks postpartum in breastfeeding women. The CDC does not have this restriction in the absence of proprioceptus. There's no evidence that this IUD has any effect on the quantity or quality of breast milk. One trial found that women randomly assigned to immediate postpartum insertion were less likely to be breastfeeding at 6 weeks to 6 months after delivery than those whom insertion was delayed. The number of breastfeeding women was small, precluding a clear conclusion about the effect of early insertion on breastfeeding duration. As described above, IUD insertion during the breastfeeding period appears to be a risk factor for uterine perforation. Progestin only. If hormonal methods are to be used, progestin-only contraceptives are the preferred method for breastfeeding women because these drugs do not appear to affect milk volume or composition or to cause deleterious effects in the infant. However, the timing of initiation of therapy immediately versus 6 weeks is somewhat controversial because falling progesterone levels trigger lactogenesis. Early initiation of progestin-only contraceptives theoretically could interfere with the process, particularly if an injectable contraceptive is given within the first 72 hours after delivery. In addition, the immature metabolism of neonates theoretically could lead to accumulation of progesterone and its metabolites in the infant. However, most available data suggest that early initiation of progestin-only contraception does not impair and may increase lactation and is not harmful to the neonate. CDC medical eligibility criteria provide the least restrictive guidance and indicate that progestin-only hormonal methods, including progestin-only pills, depot, implants, are safe for postpartum women, including women who are breastfeeding, and can be initiated immediately postpartum. We agree with the CDC recommendations. We try to highlight, and you can't do it because I did the cut and paste.
Yeah, that's all right, though.
In contrast, manufacturers package insert recommend starting progestin contraceptives 6 weeks postpartum if the mother is exclusively breastfeeding and 3 weeks postpartum if she is supplementing with formula. The WHO also suggests that breastfeeding women initiate oral injectable or implantable progestin-only contraceptives 6 weeks postpartum. Even if the clinician usually chooses to wait 3 to 6 weeks before initiating hormonal contraception in certain clinical situations, including concerns about patient follow-up or when an unintended pregnancy would be associated with elevated risks, it may be appropriate to start progestin-only contraception earlier. Many experts believe the real maternal risks of unintended pregnancy outweigh the theoretical risks to the infant and thus endorse depot use immediately postpartum regardless of breastfeeding status. Estrogen progestin, theoretically, estrogen progestin contraceptives, pill, patch, and ring could suppress milk production in the early postpartum period. 2 studies have reported data supporting this hypothesis, but there's no strong evidence of a significant difference in infant outcomes due to the use of hormonal contraception during lactation. And then it gives these 3 studies. I know that I have to read all of those. Recommendations from the CDC and the WHO are discordant. The CDC strongly recommends delaying initiation of estrogen progestin contraceptives until 21 days postpartum in all women because of increased risk of venous thromboembolism and considers the risk greater than benefit until 30 days postpartum in women with no additional risk factors for VTE because of possible detrimental effects on milk supply. In women with additional risk factors for VTE, estrogen progestin contraceptives should not be initiated until 6 weeks postpartum as long as the woman meets standard criteria for use of combined hormonal contraception that apply to non-pregnant women. We agree with this recommendation. WHO recommends delaying the initiation of estrogen progestin contraceptives until 6 months postpartum. Between 6 weeks and 6 months, WHO states that the theoretical or proven risks usually outweigh the advantages of initiating these drugs.
Okay, now this question's a little kooky. I just want to let you know, in my notes, this is a question in my notes. I don't want to write it the same because I don't want it to get kooky. So this is what I wrote. This is what my notes read. 2 weeks out. 2 weeks. Let me read what my notes said first, so it's a little wacky. 2 weeks after delivery, which birth control would decrease milk production the least? Now, I think mine's closed. Yeah, it was the same thing. But I don't have any choices here. I don't have any choices at all. So what I had to do is I had to make up some choices to make a question here. So let's see what you think.
Okay, Implanon mini pill, combined oral contraceptives, or the Mirena. Decrease milk production the least.
I know, isn't that crazy? Decrease least. I mean, what the hell? This like what just twists my head on backwards for crying out.
Yeah, decrease milk production the least. The least.
So all
I don't know, the Mirena?
Yeah, Mirena. Yeah, because you know why I think it's the Mirena? Because the Mirena is localized to the uterus. And there's not that much systemic symptoms associated where all the other ones have to do some kind of first pass through the liver, you know?
Yeah.
So I would go with D. I mean, you guys can disagree with me on that. I don't know. Let's see. Implanon and mini pill would be the same. B, probably Mirena. You can put the IUD in for 6 weeks, but they're just saying would. They're just saying would. They're not saying, okay, a patient's having, which one would you put in? They're just saying overall of all the birth, which ones would decrease milk production the least. Although you can't put it in, the levonorgestrel in for up to 6 weeks after delivery. I think they're just asking you, you know, theoretically, which ones would decrease it the least. So
right.
Okay. Yeah, they don't decrease milk production, but if you're thinking about, somebody sent me a text, well, I thought all the progesterone ones don't decrease milk production, but the least overall is going to be the one that's the closest to the uterus, that it's not going to be in systemically. So they'll be trying to put Mirena in me. Okay, so, okay, some people are, she says somebody has texted me that they're trying to put it in postpartum. Okay. I guess if you had an uncomplicated delivery, you know, expulsion rate is high, but it's being done. Oh, okay. That's what I would put if I was taking the exam, you know.
Yeah. Yeah, that's a good argument.
Yeah, okay, number 3.
Which contraception decreases the transmission of gonorrhea? So latex condoms, when used consistently and correctly, can reduce the risk of transmission of gonorrhea. Surest way to avoid transmission of gonorrhea or other STDs is to abstain or to be in a long-term mutually monogamous relationship with a partner who has been tested and is known to be uninfected. Then the results of this study, I guess through the CDC, indicate that OCs reduce the clinical development of salpingitis in women infected with gonorrhea. Although the incidence of cervical infection with chlamydia trachomatis has increased in OCs as compared with controls, Molnar, Hansen, and co-workers reported that the incidence of chlamydial salpingitis in OC users is only half that of controls. This protection may be related to the decreased duration of menstrual flow, which permits a small number of organisms to ascend to the upper genital tract and allows the body's defenses to eliminate them more easily. One sequela of PID is ectopic pregnancy, an entity that has tripled in incidence in the past decade. OCs reduce the risk of ectopic by more than 90% in current users and may reduce the incidence in former users by decreasing their chance of developing salpingitis. Okay. So which of the following contraceptive agents reduce the incidence of salpingitis? Oral contraceptives.
Yeah, exactly.
Okay.
Makes sense. Good. Pretty straightforward. Okay, number 4.
Following a D&C for molar pregnancy, your patient's HCG has been decreasing and was 0 at 10 weeks. You repeat it the 12th week and the level is now 25. What is the next step? And I don't even know that I put my where I got this. I'm trying to remember where I pulled this out of.
Okay, no. I added a bunch of...
Oh, you added. I'm sitting here looking at this going...
I didn't do this.
Yeah, I went kind of more quickly on this assignment, but I know I got some from one of the practice, a little bit from a practice bulletin. So here's what you put. As long as HCG values are decreasing after a molar evacuation, no role for chemotherapy. However, if HCG levels increase or plateau over several weeks, immediate evaluation and treatment for malignant post-molar gestational trophoblastic disease are indicated. Occasionally, the plateauing or increasing HCG levels are a result of a false positive laboratory test caused by heterophilic antibodies cross-reacting with the HCG test. Such false positive test results, also known as phantom HCG, are discussed later. The diagnosis of malignant sequelae as indicated by the need for chemotherapy include the plateau or increase of HCG levels after evacuation of hydatidiform moles. As mentioned previously, the histologic diagnosis of choriocarcinoma or invasive mole on the basis of findings from uterine curettage or identification of clinical or radiographic evidence of metastases. BP curettage is not recommended because it does not often induce remission or influence treatment. It may result in uterine perforation and hemorrhage. Here's the little piece I put in.
Right.
In patients with molar pregnancy, the preferred method is suction DNC. After a molar evacuation, all patients should be monitored. The serial HCG determinations to diagnose and treat malignant sequelae promptly. It's like I was just trying to look for an exact answer to this. Most patients with false positive HCG values have low-level HCG elevations, but occasionally values higher than 300 have been recorded. False positive HCG values result from interference with the HCG immunometric sandwich assays, most often caused by nonspecific heterophilic antibodies in the patient's serum. Many of these patients have an undefined previous pregnancy event and do not have radiographic evidence of metastatic disease. False positive HCG values also may occur after evacuation of a hydatidiform mole or following a clearly defined pregnancy event, such as an ectopic pregnancy, and a urine pregnancy test may be considered to differentiate between the two. False positive test results should be suspected if HCG values plateau at relatively low levels and do not respond to therapeutic maneuvers, such as methotrexate given for a presumed persistent mole or ectopic pregnancy. Evaluation should include evaluation of serum HCG levels using a variety of assay techniques at different dilutions of patient's serum, combined with the urinary HCG level if the serum level is higher than the threshold for the urinary assay, usually more than 50 to 60 milliIUs per mil. False positive HCG assays usually will not be affected by serodilution of patient sera and will have marked variability using different assay techniques, with most assays reflecting undetectable HCG levels. Heterophilic antibodies are not excreted in the urine, therefore urinary HCG values will not be detectable if they are the cause of serum HCG level elevation. Other techniques also are available to inactivate or strip the patient's serum of heterophilic antibodies. It is important to exclude the possibility of false positive HCG values before subjecting these patients to hysterectomy or chemotherapy for gestational trophoblastic disease. Okay. And then an up-to-date diagnosis of persistent disease. Any of the following findings during the period of gonadotropin follow-up is suggestive of malignant gestational trophoblastic neoplasia and warrants treatment. A plateau in serum HCG concentration for at least 4 values over 3 weeks, so that's early on. Serum HCG concentration that rises by 10% or greater for 3 values or more for 2 consecutive weeks. Persistence of detectable serum HCG for more than 6 months. So your question was it went to 0 and then came back. Histologic confirmation of choriocarcinoma. So after being treated for a molar pregnancy, a patient's beta HCG is starting to rise at week 12. What is the next best step?
This is a tricky one.
Okay. I know there's a similar question to this, I think, in the prologue. I'm going to go with A.
Okay.
Repeat the beta.
Right, you know what the thing is with this?
Uh-oh,
I
got
think,
it wrong.
No, listen. I think, see, I have a question, some of this in my test file, but I think it's a little bit different than this, and it didn't ask for so much specifics. But I think what we need to do, it says you need to have a plateau in the serum HCG for at least 4 values over 3 weeks. And this is the first one, right? Or an increase.
Right.
So I don't think you need to go wild just yet. A serum HCG concentration that rises by 10% or greater for 3 values or more over at least 2 consecutive weeks, day 1, 7, and so this is at week 12. After being treated for a molar, patient's beta started to rise at week 12. So I'm going to assume for what they put here that she was 0 on week 11. I mean, week 11, she was 0. Now, on week 12, it has gone up. So they're not telling
Yeah.
us what it's on. So is it a true rise, or is it a false rise, or is she pregnant again? Or so I think the right thing to do here before you jump to the gun is probably repeat the beta again in a week. And if anybody, heterophilic antibodies, I think that's a reasonable option if after. I mean, that's the problem that bothers me here, because I know so much about this heterophilic. Do we go ahead and do a pregnancy test now and check to see if it is a heterophilic, or we just monitor it a little bit longer, you know?
There's a really similar question in the 7th edition GYN prologue. It's almost this question.
And what did they say to do?
So they say, basically it says 24-year-old woman comes to the ER with vaginal bleeding, had suction curettage for a complete molar pregnancy 11 weeks ago.
Right.
Pre-evacuation beta was 285,000. Quantitative beta level last week was 2,485, and it's found to be 2,450 today. So, I mean, it went down a teeny bit, but it's at the same time period, and they say the most appropriate management is, and there's some similar choices, and the answer is quantitative HCG in 1 week.
Okay. Okay, then I agree with that then. I agree with that.
That's page 74, question 54.
Okay, let me put that in here because everybody's texting me. They're going wild over this. Okay, so GYN surgery prologue, similar question, 7th edition. Oh, sorry. Page
74.
74, question
54. Now they do have higher values. On this one, you went to 0, but
right now let me read you from my notes. Now let's read from my notes because the notes may say something different. Because I don't want to be in the whole stupid copyright infringement. So we got to be very careful what we say on the webinar. All right. Hang in there just 1 second because it's kind of like all over the place here. I mean, they're organized, but they're all over the place. Okay, this is the notes. Following a DNC for molar pregnancy, HCG level has been going down well. This is what my notes say. At 12 weeks, it's 25. What do you do now? That's all I have.
Huh, all right.
It's similar.
Uh-huh. Yeah, I mean, this one at 11 weeks was 2,400 in this question.
Right.
So, you know, it's just...
At 12 weeks is 25. It's been going down well. Now see, they're not saying going down well. Did it go to 0 or has it been, and now it's hovering, you know?
Right.
So that's a thing. Okay, now, somebody just sent me a text. They said, this question in prologue describes a plateau, but your original question states that the beta went down to 0, and now it's coming back up again. So why don't we make it that being treated for more patients beta HCG is starting to rise at, see, well, I never said here that it was 0. After being treated for more patients beta is starting to rise at week 12.
It was, I think, your original question.
Right. Oh, okay.
The
Okay.
homework question.
Right. Okay, gotcha. It's a little bit different than what
Yeah.
I thought, yeah. Yeah, see,
they're a little different.
I don't want to be, you know, I don't want to get into the copyright infringement thing, so that's why I try to switch them around a little bit. Yeah, see what I mean? 0 is the key. Okay, so why don't we say that if it's 0, then we're going to go for heterophilic. If it starts to plateau, then we need to follow the HCGs. I think that's a reasonable, and I'll bring that up at the camp too. You know?
Okay.
Does that make a reasonable option? So let's say after being treated for beta HCG is starting to plateau at week 12. Let's say plateau.
Okay.
Starting to.
So if we're saying that, then we could say, then we'd do the repeat beta.
Yeah, and that's, I think, what we should do. Then it would be A. Okay, everybody agrees with me. Let's say question is changed and the beta was 0, and now 25. Answer would be heterophilic. Do you agree with that?
Yeah. Uh-huh.
Okay. That's not right. Okay. Okay, everybody agrees with me on that. Okay, good. Okay, number 5. Let me move this down so it looks prettier.
Number 5.
There you go. Good.
Best way to diagnose appendicitis. More than 250,000 appendectomies. Appendicitis is the most common abdominal surgical emergency in the U.S. Diagnosis of acute appendicitis is generally made by the history and clinical exam. Diagnosis is supported by laboratory and/or imaging findings. Diagnosis of acute appendicitis can be difficult, and a delay can result in perforation rates as high as 80%. Challenging clinical settings include children less than 3 years of age, women in the second and third trimesters of pregnancy, due to the displacement of the appendix by the uterus and the resulting changes in the physical exam. Alvarado score is the most widely used diagnostic aid for the diagnosis of appendicitis and has been modified slightly since it was introduced. However, clinical judgment remains paramount. Modified Alvarado score, a scale, assigns a score to each of the following diagnostic criteria. Migratory right iliac fossa, pain is a point, anorexia, point, nausea, vomiting, point, tenderness in the right iliac fossa, 2 points. Rebound tenderness in right iliac fossa, point, and fever greater than 37.5 Celsius, a point. Imaging studies. Now, this was this was just a repeat question, so this may look familiar to people.
That's okay.
Spiral CT examination of the appendix may be of help in diagnosis. An enlarged appendix with wall thickening or enhancement of periappendiceal fat stranding are the most useful CT findings of acute appendicitis. Other findings may be present, including focal cecal thickening, appendicolus, extraluminal air, intramural air, and paracecal phlegmon, but are less reliable. CT scans are of greatest value in patients with less than typical clinical and lab findings, where a positive study would be an indication for appendectomy. In the face of typical time course of disease, right lower quadrant pain and tenderness, plus signs of inflammation like fever, leukocytosis, a CT scan would be superfluous and, if negative, even misleading. Ultrasound imaging is much less reliable. In CT, when appendicitis is accompanied by right lower quadrant mass, an ultrasound or CT scan should be obtained to differentiate between a periappendiceal phlegmon and an abscess. Then appendicitis during pregnancy, I'll just go down to the highlighted. By far the most common presentation is right lower quadrant pain and tenderness. The classic syndrome, but the enlarged uterus occasionally will have pushed the appendix into the right upper quadrant, which gives rise to pain in this location. Fever is less common than with appendicitis in the absence of pregnancy. Leukocytosis is typical but may be absent. For all these reasons, pregnant women, especially those late in gestation, frequently do not have clinical findings typical for appendicitis. It's commonly confused with cholecystitis, preterm labor, pyelonephritis, renal colic, placental abruption, or degeneration of a uterine myoma. Most reports and we can just, let's see, treatment. The great majority of patients with acute appendicitis are treated surgically, and an appendectomy remains gold standard of care. However, at least in theory, non-surgical management of non-perforated acute appendicitis may parallel similar management of acute non-perforated diverticulitis. We can just go down to the question. Yep. In a patient with appendicitis, the diagnosis is generally made with history and physical.
Yeah, there you go. Straightforward, right? That's just,
right.
That's just common sense.
Right.
All right, number 6.
Patient has an IUD in place and diagnosed with an 8-week pregnancy. What are the complications that can occur if she was to leave the IUD in place? Now, this I just, again, cut it from up to date. So first trimester pregnancy, if the IUD strings are visible, remove the IUD to decrease the risk of subsequent miscarriage, infection, and preterm delivery. If strings are not visible and the patient wishes to continue the pregnancy, we suggest removing the IUD under ultrasound guidance using alligator forceps or Bozeman uterine packing forceps. Removal can also be attempted by hysteroscopy during pregnancy. Wow. Data on hysteroscopic removal of IUDs in early pregnancy are limited, therefore not clear whether this technique poses greater or lesser risk of pregnancy loss than instrument removal under ultrasound guidance. We recommend antibiotic prophylaxis when instrument removals are performed during pregnancy. If the IUD cannot be removed by pulling the strings or removed easily using other instruments under sonographic guidance or hysteroscopy, the IUD may be left in situ. The risks of pregnancy loss with aggressive attempts at IUD removal must be weighed against the risk of adverse maternal and fetal outcomes later in pregnancy, including infection and preterm delivery if it is left in place. If the woman desires pregnancy termination, IUD removal can be performed at the time of the termination. Manual or electric vacuum aspiration or an instrument such as an IUD hook, Bose mini impact forceps, again, elevator forceps, ring forceps, ovum forceps can be used to remove it. The strings are visible and there may be significant delay until pregnancy termination can be performed. We recommend pulling the strings to remove the IUD as soon as possible, since the strings may no longer be visible as the uterus grows, and removal may be more difficult later in gestation. Okay.
There you go.
22-year-old at 8 weeks gestation has an IUD in place. Which of the following is not a complication of the IUD? Septic abortion, spontaneous abortion, malformation of the extremities, preterm delivery, malformation, C.
There you go.
Not.
Straightforward.
Right.
That's a repeat.
Yeah.
This question's on all my exams. I mean, this is a joke. Straightforward.
Okay.
Now, let me ask you a question. Let's see how much you've been studying.
Uh-oh.
Uh-oh. Okay, tell me what perinatal infection do you see limb hypoplasia?
Okay. That's, is that rubella?
Oh, come on.
Dang it. All right.
You've proven me wrong now. You don't know anything. Come on.
All right.
Limb hypoplasia, what perinatal infection? It's not rubella. Okay, then let's push you a step further. What do you see with rubella infection?
All right. I just went over this again. It just hasn't stuck. Okay. So with congenital rubella, you will see, isn't that
radiolucent bone disease, right? Cataracts.
Okay, yes. Oh,
Patent ductus arteriosus. Mental retardation.
Right.
Those babies. Remember, rubella is the most teratogenic of all the infections, and it's highly severely problematic in the first trimester, especially if they develop a macular papular rash in the first trimester. So don't forget that, okay?
No, I know. Yeah, this I keep saying.
Okay, and then varicella is the one that causes limb hypoplasia.
Right. Yes. Yeah.
Yeah. Make sure you study those because you don't want to screw that up on the exam.
It's just a matter of remembering.
Yes, it's remembrance. And then the more you talk about it, the better you do. Okay, number 7.
Okay, umbilical Doppler velocimetry. When we order this test, what's the significance of reverse end diastolic pressure? Umbilical artery vessel normally has forward flow throughout the cardiac cycle, and the amount of flow during diastole increases as gestation advantage. Thus, the SD ratio decreases from about 4 at 20 weeks to 2 at term. SD ratio is generally less than 3 at 30 weeks. Umbilical artery Doppler may be a useful adjunct in the management of pregnancies complicated by fetal growth restriction. As presented in Chapter 15, umbilical artery velocimetry has been subjected to more rigorous assessment than as any previous test of fetal health. It is, however, not recommended for screening of low-risk pregnancies or for complications other than growth restriction. It's considered abnormal if the SD ratio is above the 95th percentile for gestational age. In extreme cases of growth restriction, end-diastolic flow may become absent or even reversed. These are ominous findings and should prompt a complete fetal evaluation. Almost half of cases are due to fetal aneuploidy or a major anomaly. In the absence of a reversible maternal complication or fetal anomaly, reverse end-diastolic flow suggests severe fetal circulatory compromise, usually prompts immediate delivery. Sezgin colleagues recently reported that fetuses of preeclamptic women who had absent or reversed end-diastolic flow were more likely to have hypoglycemia and polycythemia. And then this was another question, so I did some more about the Dopplers. I don't know that we have to.
Yeah, you probably, you know what, let's see. I didn't even put a test question here because we kind of covered it in another homework.
Right.
So, I mean, let's see. No, you don't have to read it. We'll go over it at the camp. But,
Okay.
I mean, it just goes into, what time is it? 9:46. We started a little bit late. You go ahead and read it just for everybody. It wouldn't hurt.
Ductus arteriosus. Doppler evaluation of the ductus arteriosus has been used primarily to monitor fetuses exposed to indomethacin and other NSAIDs. Indomethacin, which is used for tocolysis, causes constriction of the ductus in sheep and human fetuses. The resulting increased pulmonary flow may cause reactive hypertrophy of the pulmonary arterioles, and eventually pulmonary hypertension develops. In a study of 61 indomethacin-treated pregnant women, Vermillion and colleagues reported that half of exposed fetuses developed ductal constriction. Fortunately, this complication is largely reversible if medication is discontinued before 32 weeks. MCA, so peak systolic velocity in the middle cerebral artery is increased with fetal anemia because of increased cardiac output and decreased blood viscosity. Velocity measurements are generally problematic because a high insonating angle introduces considerable error. Middle cerebral artery measurements are an exception, however, because the path of the artery often presents a very low angle of insonation. Marie and colleagues performed velocity studies on 135 normal fetuses and 39 with alloimmunization. They reported that all anemic fetuses had peak systolic velocity above the normal mean. This prompted a collaborative study of 376 pregnancies by Mary and colleagues. Using a threshold of 1.5 multiples of the median, they correctly identified all fetuses with moderate or severe anemia with a false positive rate of 12%. Other investigators have since reported similar results. It has also been hypothesized that Doppler evaluation of blood flow through cerebral vessels might be used to detect altered cerebral circulation before there is hypoxemia significant enough to alter the fetal heart rate pattern. The cerebroplacental ratio has been introduced as an indicator of brain sparing in fetuses with growth restriction and as a predictor of adverse perinatal outcome. Currently, ACOG considers antepartum surveillance with cerebral artery Doppler velocimetry to be investigational. Then the uterine artery. Uterine artery blood flow increases from 50 mLs per minute early in gestation to 500 to 750 mLs per minute by term. The uterine artery Doppler waveform is unique and characterized by high diastolic flow velocities similar to those in systole, by highly turbulent flow which displays a spectrum of many different velocities. Increased resistance to flow and development of the diastolic notch have been associated with pregnancy-induced hypertension. In a recent study, Zeman and co-authors confirmed that increased impedance of uterine artery velocimetry at 16 to 20 weeks was predictive of superimposed preeclampsia developing in women with chronic hypertension. Now that's like investigational.
Right. Okay, so I didn't put a test question there, and because we already covered it in another one, so I didn't want to try and dig up another TQ. So this one here, number 8, let's go ahead and do that one and see how my test question is on that one.
What are the histologic changes seen with endometrial hyperplasia? So endometrial hyperplasia is characterized by a proliferation of endometrial glands resulting in a greater gland-to-stroma ratio than observed in normal endometrium. WHO classification of endometrial hyperplasia is based upon 2 features. The glandular stromal architectural pattern of the endometrium, which is described as either simple or complex, presence or absence of nuclear atypia. So results in 4 possible categories of endometrial hyperplasia.
Okay, sorry. Go down.
Simple and complex. Simple hyperplasia without, complex hyperplasia without, simple atypical hyperplasia, complex atypical hyperplasia. So women with simple hyperplasia without atypia are least likely to develop endometrial carcinoma, whereas Women with complex with atypia most likely to develop. Presence of nuclear atypia is the most worrisome finding. Simple versus complex hyperplasia. Simple complex endometrial hyperplasia are characterized by the following features. Simple consists of glands that are mildly crowded. They are frequently cystically dilated with only occasional outpouching. Mitoses may or may not be present in the glandular cells. Complex consists of glands that are crowded, greater than 50% gland-to-stromal ratio. The gland-to-stromal ratio is higher in complex compared to simple. Glands appear disorganized and have luminal outpouching. Mitoses are typically present. Nuclear atypia is the presence of nuclear enlargement. The chromatin may be either evenly dispersed or clumped. The features of atypical endometrial hyperplasia are you have complex atypical. Hyperplasia consists of crowding of glands lined by atypical cells. Rarely extreme complexity without marked cytologic atypia warrants a diagnosis of complex atypical hyperplasia. Simple atypical hyperplasia is characterized by cells with nuclear atypia that line glands that are separated by significant amounts of normal stroma. Which of the following is a histologic change seen with endometrial hyperplasia? So, stromal invasion, dilated glands, increase in mitotic figures, increase in gland to stroma ratio. Wasn't it D?
Yeah, that's what I would think, don't you think?
Yeah, yeah.
Absolutely.
That penny, nickel, dime, quarter.
Yeah, gland-to-stroma ratio. And that also changes, too, from the proliferative to a stromal invasion is more with cancer. You see stromal invasion. Dilated glands, you see in the proliferative phase, the glands start to get bigger. I mean, I don't think that means that it's hyperplastic or it's atypia. Increase in mitotic figures, I mean, nuclear atypia is pretty much nuclear enlargement. I mean, nuclear enlargement would have been a better answer if they had it here, but they didn't. It could have been a choice, though. I'm not 100% sure. It could have been on their exam. But on my exam, it's increased the gland-to-stroma ratio, I thought was the best answer here. Okay, number 9.
Patient presents at 41 weeks and 4 days. Discuss your management. So, now this is, I pulled this first thing right out of this obstetric data definitions issue. So this was off of the ACOG website, and so, it's just that we have post-term, which is 41 weeks, and I think I got that right. Oh, that's late term.
Oh, is it late term? Late term. Late term.
Hold on, late term.
Early,
right there.
Early term. Term, late term, and then post-term. That's their new. There's no such thing as post-dates anymore. Remember, people used to say, "Oh, the patient's post-date." No, it's not that anymore. And then they were saying
late preterm,
prolonged gestation, and that wasn't making any sense either. So now they have a better terminology.
Late term.
Right.
Yes.
Okay. There you
41 and 0 through 41 and 6.
There you go.
Okay. Not to suggest intervention, but suggest the need for more attention during this week. And then I just copied something. They had a reasonable summary here and up to date. Maternal risk of post-term pregnancy included increased frequency of labor abnormalities and sequelae of labor induction and fetal macrosomia. These sequelae include failed induction, 3rd and 4th degree perineal lacerations, postpartum hemorrhage, management. So it refers to singleton cephalic fetus. We favor induction. It says reaches 41 weeks. I'm skipping around. We favor induction of well-dated post-term pregnancies at or shortly after 41 and 0, irrespective of cervical status. The alternative is expectant management with ongoing fetal assessment. With intervention, if fetal assessment is not reassuring or spontaneous labor does not occur by a predefined gestational age. Both these approaches are associated with low complication rates in the low-risk post-term gravida. Induction of post-term pregnancy rather than expectant management with fetal monitoring is supported by several lines of evidence. So it says lower perinatal mortality and morbidity. 2012 meta-analysis of randomized trials comparing a policy of labor induction to a policy of awaiting spontaneous onset of labor at 39 to 42 weeks. Routine labor induction at greater than 41 weeks of gestation compared with expectant management resulted in lower perinatal mortality and a lower rate of meconium aspiration. For induction at 41 and 0, the risk of perinatal mortality was also lower than with expectant management but did not achieve statistical significance. When fetal mortality is based on the number of fetal deaths per 1,000 ongoing pregnancies rather than per 1,000 deliveries, an analysis of fetal versus neonatal mortality rates concluded that the rate of fetal demise was significantly higher than the rate of neonatal death at any gestational age, greater than or equal to 40 and 3 weeks of gestation. No increase in or a reduction in cesarean delivery. Meta-analyses have reported that routine induction at greater than 41 weeks results in no increase in the risk of cesarean delivery compared with expectant management, or a decrease in the cesarean birth rate. And then patient satisfaction. Survey of women at 41 weeks reported 74% preferred induction to expectant management. We agree with guidelines that suggest routine induction between 41 and 0 and 42 and 0 rather than expectant management and monitoring as intervention at this time reduces perinatal mortality without increasing perinatal morbidity or cesarean delivery rates. The exact timing during this week should take into account clinician and patient preferences and local circumstances. We favor induction of well-dated post-term pregnancies at or shortly after 41 and 0. However, this approach has not been universally accepted, in part because of the low absolute rates of fetal and neonatal death. At 41 weeks, 527 induction would be necessary to prevent 1 perinatal death. So they talk about cervical ripening. I was trying to remember if there were actually what ACOG said about this. And I couldn't.
You know what the problem is that their post-term pregnancy practice bulletin was pulled.
That's the problem. I knew it was there at some point.
So this topic is kind of just floating around. And the thing is that they just put the new terminology out. I would believe that over the next year they'll put some new information out on it. But the test question is really not that difficult. So
all right.
You want to just go to the test question? It's just,
sure. Yeah.
I mean, reading all this is just going to make us give our heads spin a little bit. So.
Right. A patient presents post-term. What is the least likely test? BPP, CST, AFI, umbilical Doppler. Well, I would say umbilical Doppler.
Yeah, absolutely. I mean, that's common sense. You don't really need to look up on these patients. Good. That's excellent. Good. Yeah, I mean, we did all that for really this, and it just kind of is kind of depressing. So, yeah,
it was different when there was that bulletin, I guess.
I know, and they pulled that bulletin. So anyway, okay, number 10.
Okay.
Last question.
A 17-year-old presents with a breast mass. What is the likely diagnosis and why? So causes of breast mass in female adolescents. Again, from I just got it out of up to date.
That's right.
There are a number of causes of breast mass in adolescents, most of which are self-limited and benign. Common benign breast lesions include fibrocystic disease, fibroadenoma, breast trauma, breast infection. The less common benign breast lesions include mammary duct ectasia and cysts of Montgomery, intraductal papilloma, and phalloides tumor are also usually benign but may be malignant. Malignant breast lesions, which are extremely uncommon in adolescents, include primary breast cancer, metastatic cancer, secondary cancer. Fibrocystic change. Fibrocystic changes of the breast are common in adolescents, although the prevalence of fibrocystic changes in adolescents is not known. More than 50% of women of reproductive age have fibrocystic changes. Etiology is unknown. Fibrocystic changes are thought to result from an imbalance between estrogen and progesterone. Some studies have suggested that caffeine worsens the symptoms, but others have failed to demonstrate this association. Patients with fibrocystic change present with painful breast tissue before menses and report improvement during menstruation. On exam, fibrotic tissue may be palpated and is generally found in the upper outer quadrants of the breast. Cysts are more frequent in women in their 30s and 40s. A non-bloody serosanguinous discharge may be present. Ultrasonography may be helpful in the diagnosis. Mammography is not indicated for adolescents. And then treatments in a fibrocystic change in adolescents may include mild analgesia like NSAIDs. In adults, danazol and tamoxifen have been effective, not been studied in adolescents. OCPs improve symptoms in 70 to 90% of women. Pills with 20 micrograms of ethinyl estradiol may be better tolerated than higher doses of estrogen. Then fibroadenoma are the most common breast lesions in adolescents. Fibroadenomas are typically asymptomatic but may cause discomfort for a few days before the onset of menses. Oh, well, that's the most common.
Oh, let me just fix this for a second here. All right. For all that for this.
The likely cause of a breast mass in a 17-year-old: fibroadenoma, fibrocystic breast disease, carcinoma inside two cystosarcoma fluid, ductal lactation. Well, now I'm not sure if it's A or B. I guess
Okay,
I'll
now
go
listen.
with A.
They're saying
What?
breast. They're saying breast mass. They're not saying
Yes.
masses. They're saying mass.
So A.
There you go. Yeah, make sure you.
Fibroadenoma, right?
Yeah, always go after. I mean, fibrocystic breast is something bilateral. It's bilateral, right?
Right.
Right. See, fibroadenomas are also called juvenile are the most common breast lesions in adolescents. But this was saying masses, but breast mass, right? Okay, so don't let it go. Yeah. Which are self-eliminating, common fibrocystic, fibroadenoma. So if it's bilateral, I'd go after fibrocystic disease because you don't have fibrocystic in one breast, right? Do you agree with me on that? Right.
Yes.
Right. So don't let that throw you off. Okay, Jeff, I want to thank you again tonight for doing this. I'm really happy that you went ahead and let me use your homework. You did a good job. You did a really good job, and I'll clean it up just a little bit. But overall, I think it's perfect. I think we'll send it out to everybody.
Great.
And I look forward to seeing you in Chicago.
Sounds like a plan.
Okay, great.
All
okay,
right.
this is Dr. McSherry concluding tonight's webinar. We reviewed homework assignment number 24. It is 10:03 p.m. on May 27, 2014. I'll work on trying to get this out to you guys tomorrow morning. Sorry about the delay on patient management 4. My computer froze up before I left for my trip this weekend, and I just couldn't get it out, so I got it out today, and I want to apologize for that. Okay, guys, take care. Have a good weekend, or good weekend. I'll see you all tomorrow.